Howdy, guys. Welcome to this week's image evaluation series. Today, we are going to talk about the tib fib. Uh, Tib fib is one of those ones that we don't do an awful lot, but when we do them, uh, we need to know what to expect and what to produce. Uh, Most important thing with the tib fib is including both the upper joint and the lower joint, which is the knee joint and the ankle joint on every tib fib that we take. And the reason we do that is that there's times, and depending on the mechanism of injury, a patient can have a fracture distally, and due to the mechanism of injury, it could also be a proximal fracture. And I've seen it happen a couple times where uh, somebody was asked to do a tib fib and they only got the distal portion of the tib fib, but they actually had a fracture up around the tibial plateau area, which was missed. That's why it's so important that I know it's kind of a pain sometimes, but we've got to include the entire long bone when we do take it. So for a tib fib, we take an AP and a lateral. We know that long bones, it's just two views, an AP and a lateral. Okay, piece of cake, right? Okay, so we're going to use the same acronym PACEMAN to go through these images, just so you know what you need to see on a tib fib X-ray. And there are certain ways you can accomplish this depending on the type of equipment that you do have. There's always the method of increasing your SID length to help shrink down the body parts so it will fit on one film. Some of our equipment does not do that. Some of the newer Paxos 100 units do that. The one we have here at Evanston does not. So you usually have to take two pictures unless it's an adolescent patient. Okay, so let's jump into this, guys. So here we've got an AP tib fib. Okay, you'll note that it's on the cassette a little bit crooked, and the reason that is corner to corner of the image receptor there's more space versus top to bottom. Okay, sometimes it's easier to do it corner to corner. It allows you to see more of the tib fib. Okay, and here this is an adolescent lower leg, and we can tell that due to the growth plates, right? Here, the distal femur and the proximal tib fib, and the distal tibia. Okay, uh, but rotation wise, position wise, I think we're in pretty good shape. You'll note that the knee joint line is nice and open. The proximal fibula is slightly superimposed with the proximal tibia. Okay, uh, so very, very, very minimal rotation. This is a really nice AP picture. Okay, area, we've included what we need to include. Tib fib states that we need to include the knee joint, okay, right above the knee joint, and the ankle joint, right below the lateral malleolus right there. Okay, we need to include both those on every tib fib that we take, both AP and lateral. Collimation, this is collimated very, very well. It's nice, tight collimation on both sides here. It's right to the skin margins. And we've included as much as we can include, which is more than plenty. Okay, we could have collimated to here and to here and been okay. But yeah, very, very nice job collimating. Exposure wise, we're in good shape. We can see good soft tissue. The periosteum is very well noted. We've got good bone cortical, and we're able to see joint spaces really, really nice and open. Okay, really, really nice job on the exposure. I wouldn't change anything about this. It could be a little bit lighter or brighter, I should say, but the contrast is great. So, marker, yep, there is a left marker down there, so we know this is the left tib fib, and it's on the lateral side, which is the way we like it. Aesthetics, I don't see any artifacts of any sort. I can see everything that I need to see. So it's a very aesthetically pleasing X-ray. Other than it's crooked on there, but with tib fibs, you're going to have that. Not that big of a deal. Normally, we like to think things to be straight up and down and parallel with the side of the film. But we kind of take a break from that rule with the tib fib just in order to try and fit it on one film. Okay, so very nice AP. Let's go to lateral. Okay, and here again, we've included both joints. You'll note that the positioning, the condyles, the epicondyles of the distal femur are superimposed over each other almost perfectly. So there's no rotation here. It's really, really nice lateral of the knee, which is going to in turn give us a nice lateral of the ankle. You'll note that the fibula is superimposed posteriorly on the tibia, which is what we want to see as well. Okay, but the area we've included what we need to include. We've included the knee joint and the ankle joint, which is what we want. I'm trying to nail that home with you guys. Make sure you're getting both joints on all long bones. Okay, collimation is beautiful. It's collimated nice and tightly. We're right at the posterior skin margin of the calf. We can see the popliteal area very, very well. And anteriorly, we're in good shape. It's really, really nice. Exposure-wise is beautiful. You can see good soft tissue and bone correlation, good joint spaces. It's brighter than the AP was. This is what I mean by brighter. You know that this is a little bit darker. We've still got good contrast, but the picture is actually darker than the lateral. Here we've got good contrast as well, but the picture is actually brighter. Okay, and that can usually be done post-processing. We do have a marker. This is a right, so it's placed anteriorly on the lateral. Very, very nice job. Other than it's upside down, but we can live with that just as long as it's there. Aesthetics, I don't see any foreign objects or anything like that. So I think we're in pretty good shape. Very aesthetically pleasing lateral tib fib, and you'll note that this one is actually parallel with the side of the film, which actually looks better than that. But like I say, with a tib fib, we kind of draw outside the lines a little bit with these ones. So anyway, good job on the lateral. So yeah, just so you know, this is what we need to be seeing on an AP and a lateral tib fib. Okay, both joints and everything in between, and collimated as good as we can. So let's look at a picture that was taken. This was taken a while ago. I don't know. There's a few issues with it. The biggest issue is we don't have a knee joint and we don't have an ankle joint. We just got everything in the middle. Okay. And like I said before, if this patient happened to have a distal fracture on his tibia or her fibula, we wouldn't know it. So it's important that we get both joints, and that's the only reason I put this picture up there, just to show you the information that we're missing and the information that we should have. In this case, we would want to split that into two pictures, take an upper and a lower, or vice versa. Okay, I've got a little depiction of that right here. This is a picture that we took, I don't know, 6 to 8 months ago, I guess. But we couldn't fit the whole thing on one film. So what we did is we actually took an upper and a lower. And it's really easy, especially with a femur or a tib fib. Just make sure you've got some overlap so you're not omitting any information in the middle of the leg. Okay. So in this first one, we've included the knee joint. We've got both epicondyles, lateral and medial, or lateral and medial. A good joint space right there. We've got the intercondylar eminence right there. And we're slightly superimposed with the fibula and tibia. uh, proximally. You'll note that this patient does have a proximal fibular fracture right here. Okay. And that's what I'm talking about. If we would have taken a lower image and not included this up here, we would have missed that fracture. And I've seen that happen before, where a subpar tib fib was taken, and the patient comes in a week later still experiencing pain. Uh, and we took a proper picture, and we noted the fracture. That's where issues start to happen, and there's some legalities that can start to sneak in at that point. Make sure you're including everything you need to include on every single image. And with a tib fib, it's upper and lower. Whether that patient has lower tib fib pain, you need to include the knee joint. Okay. Just for the fact that if something happened down here, something could happen up there due to mechanism of injury. Weird things happen, right? And I'm trying to get you guys to understand this. This is one thing that I see a lot when people do tib fibs is they're not including the whole bone. We need to include that, for this fact, and this fact only is you can miss stuff. So here we've got the AP, we've got an upper, we've included the knee joint. We've omitted the ankle joint down here. So what do? We move our tube down, and we include the ankle joint. So this just aids my example here. So if a tib, this is the same patient. If a tib fib was ordered, and this is the image that we took and submitted, radiologist would look at that and say, hey, we can't see all this bone, but I don't see anything. And provider says, okay, well, that's okay. Let's just go with the negative result. Patient comes in a week later, says, hey, I'm still hurting. What's going on? We go and take the proper image. We've got a fracture up here proximally. We would have missed it. Okay. This is why we take two images. Make sure the whole bone is there. Okay. Sometimes it takes two images, and that's okay. It's no sweat off our brow. Taking x-rays is fairly easy. It's just positioning, right? And techniques are built in. Just make sure you're getting the entire picture for the doctor to make a proper diagnosis. Okay, so we've got an upper including the knee joint, an up or lower including the ankle joint. Lower doesn't show the fracture, upper does. Okay. Anyway, I hope this is helpful. Tib fibs are cool. They take a minute to get used to try and finagle your patient to put it on their crosswise. Uh, Sometimes it's easier just to put them on the table, take an upper, take a lower, because I venture to say 70% of the time you're not going to be able to fit the whole bone on one image unless you have the capability of increasing your source to image distance, which some of our machines do not do that. Some of the traditional, like Afton and those in Boise, do that. And at that point, you can usually fit the whole tib fib on one film. And there's some of the Paxis units, the newer ones, that allow you to increase your tube SID where your image receptor stays the same. If you have that capability, use it. Then you only have to take 2 pictures instead of 4. But always remember, any long bone, be it a humerus, radius ulna, femur, tib fib, you've got to include the upper joint and the lower joint. Okay. I hope this is helpful. If you ever run into an issue where you're not getting everything that you need to get and you can't quite figure it out, don't be hard on yourself. Just give me a holler. We'll get it figured out for you. Okay. Enjoy the rest of your week. I hope you're enjoying your October. It's been a good one for me so far, and appreciate you guys. Keep working hard. Have a good rest of your day. We'll see you.